Tonight's topic, it's going to be all about auxiliaries and predictability. And the concept is that how can we improve efficiency by addressing limitations in clear aligner therapy? Now, when I was thinking of this topic, I was I don't want it to be something like, oh yeah, you place elastics and everything. Sometimes the reason why we're asking for auxiliaries and predictability because there is an internal issue that we actually need to address. So if we were to start right now, what is predictable? If you're gonna ask that question now, right now you're sitting and you're looking at your aligners. What is predictable, and what should I say about predictable? Now you've heard, I believe, some of you here have heard some stuff about clear aligners that, oh, it doesn't work, it's not good with this, it's not good with that. Uh, I usually take it with a grain of salt. Now, the idea is the main issue is predictability. How can I make it predictable? They designed my plan from start to finish, and here I am, right here in the middle of my treatment, and I'm wondering how come it's not following my simulation? Because again, you have to understand that predictability has a lot of influences. Now, if we're going to influence this predictability, it actually can come to two things. Number one is it can be your biomechanical design, and number two, it can be the force generation or the body response of your patient. Now, if you're going to look at it this way, biomechanics talks about your staging, talks about how you set your objectives. It also talks about your attachments and your auxiliaries. Now, your force generation and body response acts like your activation, your patient compliance, and also your plastic characteristics. So, having that said, it's not just always, okay, it's not always the plastic's fault. It's not always the treatment simulation's fault. Sometimes it can be into this dimension. Now, predictability in such a way that we have to understand how clear aligners work and how does our patients respond to it. Now, basically, doctors, predictability and the use of your auxiliaries actually rely on the basic principles. Now, I'm not gonna go with this one by one, but just to give you a breeze through, it's only five things. It's only a few things. First concept is aligners push T. It goes without saying that if you're looking at your cases and you're thinking with a context of pull, similar to how you think of your conventional appliances, your predictability or your treatment success is going to be a little bit different because the perspective is a little bit different. So try to think of whenever you're going to design a mechanics, where am I going to push it? How am I going to push it? And how am I going to deliver it to my objectives just by pushing? So just by the concept of pushing, it helps you set your predictability understanding to a different level. Now, the next context is definitely for clear aligners, multiple movements can be programmed. Now, in that sense, you don't have to wait, let's say, it doesn't go like this where you can level and align, space consolidate, finish all at the same time. You cannot do that. Even for clear aligners, you cannot do that. Okay. All right. So I'm gonna get the hand raising later on. Okay. So multiple movements can be programmed. Okay. So for clear aligners, it goes something like this. Now, for fixed appliances, basically, you have to start with your round wire. All right. You have to start with your round wire for crown movements. And then you just have to wait for your rectangular wires to start your your root movements. Now, for clear aligners, basically, you can do all those things at the same time. You can move the crown, you can move the root, even on the same stage. So that's the beauty of it. You're not dependent on the dimension of your appliances. You can actually program them one by one. Now, the next principle is basically anchorage is still required for efficient suit movement. Now, we can do magic. We can simulate your teeth to wherever it's gonna be. But one of the main reasons why off tracking is detected during treatment is because number one, anchorage is not actually considered. And the next thing is, of course, space is required for your teeth to move. Now, the most common cause of low predictability movement is because of these two things. Number one is your anchorage. Maybe it's insufficient, maybe it needs reinforcements. That's where your auxiliaries will come in. Now, space is also required for your teeth to move because you cannot just push someone and then hope for it to bypass. Now, the difference between clear aligner and your fixed appliances, your uh, your fixed appliances usually works with statically indeterminate system. So meaning once you place your wire, you place your bracket, they tend to find their way out. That's why for conventional systems, you always see your teeth whenever you place your round wire, they tend to procline. They tend to move a little bit more forward sagittally. Now, for clear aligners, since you have more control onto that aspect, space is definitely required for you to facilitate any movements that you want to do. And lastly, this is something that is usually missed by doctors who have been practicing clear aligners or for those who wants to go into clear aligners. Usually, it's easy to understand that aligners push teeth. That's very easy to grasp. Now we can program crown and root movements. It can be in one stage. We can consolidate and a little bit align even on clear aligners too. Now anchorage is good and space is needed. Now overcorrection and programming should actually be anticipated for effective treatment because most doctors fail to understand that your plastic also has their physical properties that we have to recognize. And don't worry, we're gonna go through it. I'm gonna show you just a slide or two, I think 3 slides on it. That shows how important your overcorrection and programming is. Now, a classic example, okay? A classic example of any clear aligner case is something like this. I have a spacing. I have to consolidate my space. If I'm going to use fixed appliances for this patient, I have to start with a round wire, perhaps just to prevent it from proclining. I might have to place some stop loop here, tie it back so that it doesn't procline during the initial movements. And then I'm going to wait for my rectangular wire so that I can fully consolidate them. Now, for clear liners, I can actually plan it like this. All I have to do is follow all those principles where I can understand the concept of push. Basically, my objective is just to push them in. Next is I can plan multiple movements. So I can align and consolidate the space at the same time. Number three, anchorage. I have good anchorages here. That's why in this simulation, what you're seeing is there are attachments involved so that it can develop the help on my anchorage. So basically what you're seeing here is just an alignment, all the principles going into together. So there is programming involved here where we move the teeth one by one, okay? And somehow a little bit of overcorrection on how to finish the whole case. Now, basically, having that said, since all those principles are satisfied, we can get a result something like this. Spaces are closed. We maintained our anchorage so well, although a little bit of refinement because we might have to do a little bit of overcorrection, but nonetheless, it's still a good case. Now, going back, what influences your predictability? It can be your biomechanical design or your force generation. Now, what we just talked about there, the principles actually covers the two of this one. Okay, the two of this. Okay, so another concept that you also want to recognize is just in case you want to do intrusion. Now, in terms of intrusion, of course, if you want to simulate it on your treatment, and if you're the guy who doesn't want to use attachments for their approaches, what you're kind of expecting is it's gonna be intruding like this. But the problem is basically it's not going to happen because what happens is if you program these lower anteriors to intrude, what really happens is you're actually forcing your aligners to lift on the posterior. So, having that said, in terms of predictability, how am I going to intrude this one properly is through the design of your anchorage. So basically, it still goes back to the basic principles. If I want to push this, I have to consider my anchorage here. Now, if I don't want to do it so much, perhaps I can place my attachments on my premolar so that I can somehow control it. It's like your reverse curve of SPE, but translated into aligners. So basically, if I want to intrude this one, okay, there's a push going on here, but because of the third principle of anchorage, what happens is for every action, there is an equal and opposite reaction. So basically, this one extrudes not because we programmed it to extrude. It extrudes because there is a force coming here, and this turns out to be the reactive force. Okay? So one element of your predictability and your auxiliary selections is through the use of your staging. Now, if you've been to clear aligner sessions and they talked about staging, it's just about, I mean, they talked about that I'm gonna move this first, create space like this, and then it gives you a nice simulation. But doctors, when you say staging, for fixed appliances, it's like your sequencing, it's your leveling and alignment, space consolidation, and your finishing, and all that happens in between. But once we talk about staging in clear aligners, it's actually a breakdown of your intended movement in a sequential manner. So if you're going to look at it this way, it is something like this. Staging is broken down into three main elements. So it's like a symphony. It's like a song. It's like an orchestra of things. Staging is broken down in such a way that usually the first step is space creation. You have to create space because it follows the fourth principle. Now, manipulation, it follows the rest of the principles, and conclusion, it follows the rest of the principles. So let me just give you an example on how staging works. Now, staging in terms of this context is, let's say you have a deep bite. Now, what happens on clear aligners is the usual deep bite staging, or sorry, let's go first to your fixed appliances. When you place a round wire on this kind of case, what happens first, right? You place a round wire, what happens is it proclines. And then what you're going to do next is perhaps you're going to place an auxiliary wire with an intrusion arm, or perhaps place studs and then pull it up. Therefore, you're doing intrusion. Now, on the next step is basically you're just using your rectangular wires to entirely finish the whole case. So for your fixed appliances, technically it goes a little bit automatically through the interaction of your brackets, wires, and your elastics. But for clear aligners, it's not entirely different. To be perfectly honest, it's not entirely different. It's still the same fundamentals in orthodontics. The only difference is that you have to stage it. You have to recognize the movements, the physical movements, everything that happens in physics, and then convert it into a simulation. That's why staging is given birth. Now, deep bite usually goes with a few steps of proclination, a few steps of a little bit of alignment, and then since you created the space now, you can somehow align it. And since you have the space, you can now perform the second step, which is intrusion. Okay? There's a second step, which is intrusion. And then eventually, you're going to retract. So that is the usual staging for clear aligners, especially for deep bite. So like in this case, for example, where we have an issue here. Now, without any knowledge for clear aligners, basically, if you're gonna stage this one without the knowledge of any deep bite staging or whatever staging that is, I think you can somehow break down how are we supposed to stage this one, or how can we improve the predictability of this one. I cannot just align everything and then everything is gonna be finished. I cannot make it predictable. So basically my staging is something like this. I might have to create space, right? I might have to create space. Once I create space, perhaps I'm gonna align. And then on the next phase of my staging, I'm gonna manipulate. What's my main problem? That's deep bite. So I'm gonna have to intrude. And then conclusion, perhaps I'm just gonna finish the inclinations of the teeth. So staging is something like that. Now, as you can see here, here's the animation of the simulation here. What it does and how it's broken down. Space creation is done first so that we can fix the crowding. And what happens here is we're performing a little bit of expansion, a little bit of proclination, and then a little bit of IPR on the posterior and on the lower. Now, in terms of manipulation proper, we're actually intruding. Okay, we're actually intruding on the anterior. And on the conclusion, we're somehow performing a little bit of retraction. Okay, retraction on this part, settling, and some form of overcorrection. Now, basically, doctors, this is the summary of this simulation. If you're just gonna look at the simulation, you're gonna be a little bit bamboozled of what's going on here. Oh, everything's happening all at once. But if you're gonna look at the staging pattern, it's actually something like this. Okay. So what happened here is basically after a lot of aligners, it actually ended up with something like this. Now, there is something wrong though, or there's something that we missed, because on the simulation, everything is leveled on the plane of occlusion. And now what we have here after completing the entire sets of aligners, there is an open bite on the posterior. Now, in the context of predictability, it's still predictable because we have delivered it to the objective where we have reduced the overbite and the overjet, but the problem still remains. In terms of predictability of my simulation to the actual plan and to the actual clinical delivery, there is still a little bit of discrepancy. Now, how do we actually fix that? Or what am I missing? What we're missing is actually considering the properties of your plastic. Because biomechanically, we provided or we performed all the necessary approaches or we performed the necessary movements. But what we did not consider is step number 5 or principle number 5, which is overcorrection. Now, the reason why we perform overcorrection is you have to overcome the physical properties of your plastic, which I will discuss in a short while. But as you can see here, all right, as you can see here, that once we deliver the aligners, let's say we just place it based on the treatment objective, it did align quite well, but the problem is programming is insufficient. Therefore, treatment becomes a little bit less predictable. In what sense? We missed out on some few things because we did not consider how the anteriors will react. Now, if I were to drill it down, what happens here is there is a posterior open bite, which is not present in the simulation, but it is present on the clinical. Now, usually doctors, when I'm looking at predictability thresholds, I'm always looking at the patient's clinical setup. Okay. So what I usually do is I make treatment checkpoints on my simulation. So basically, if this case is going to finish, let's say in 40, 50 aligners, what I'm going to do here is perhaps on the fifth step, I'm going to ask the patient to come back. Okay, let's see if your teeth follows what is in the simulation. All I have to do is just do an inspection, review it, and if it doesn't fit or if it doesn't work, what I'm gonna do here is basically I'm gonna have to do a rescan, perhaps a replan. And since let's say SEBARIS haven't manufactured 6 to 10 yet, I can submit it to a plan. I can furnish or fix the plan on 6 to 10 with the new scan and an updated plan. So basically, I'm saving plastic, and of course, I'm doing proper orthodontics at that point. Now, here's a study that explains why that after my simulation, I still get this posterior open bite. How come the intrusion is insufficient, even if on the simulation, it's actually correct? Now, just to summarize these two theses or these two journals, basically, they concluded that 40 to 50% of the forces are lost within 24 hours of activating your aligners. So meaning, if you're planning an intrusion of 1.5 millimeters, you're just getting around 0.75 in total. So meaning, if I'm getting around that one, meaning I have to increase the number of steps for me to make sure that I get 1.5. So how does it work this way? Now, the reason behind this thing is it's not because the planning is incorrect. It's not because that the patient's not compliant. It's not because you're not doing a good job in diagnosis and treatment planning. It's actually an innate issue in all plastics, where once it's subjected in water, from a 7 Newton force, they decrease to around 4 to 5 Newton. So meaning it's like 40 to 50% of forces that are lost within 24 hours when they immersed it in water. So it's not your fault. It's not the patient's fault. Sometimes it's the fault of your plastic. That's why we branch it out into two things, right? It can be seen on most evidences on expansion, where they have found out that most of the expansion actually happens on your premolar and it decreases to your posterior teeth. Now, as you can see here, there are a lot of factors that goes in it. Number one is because plastic creep. Plastic sets in. It deteriorates after 24 hours. Number two is because the size of your teeth. Now, premolars are going to yield for whatever force that you're going to deliver, but not your molars because molars are heavy. So just imagine you have a thin guy and a big guy, and you're pulling them at the exact amount of force. The reaction of the big guy is going to be entirely different from the reaction of the thin guy because the thin guy might react a little bit exaggerated to the force that you just delivered. So it goes the same thing with your plastics. Okay? It goes the same thing. Now, the way we usually finish this one is once you talk about overcorrections and once you talk about your plastic creep, the height of your plastic is also considered in such a way. That is why whenever you're going to look at the finishes of your clear aligners, what you want to have is no contact on your anterior, but posterior contacts are actually present. The reason behind this one is because the thickness of your plastic together with the ideal overbite and overjet. Ideal overbite and overjet is not 0, 0. It's actually 1, 1, meaning there is a 1 millimeter overbite and a 1 millimeter overjet, and it doesn't really touch. Okay? And on the plastic perspective, the thickness of your aligner here on your occlusal is around 0.75 or around 0.65. But as it goes to the anterior, it becomes zero point 0.4. So just imagine a thin portion of your aligner. Once you remove both of those aligners, definitely your anteriors is going to contact first before your posterior. That is why if you finish your case with contact on the anterior, most of the time you're going to see posterior open bites. Okay? Because of that predictability criteria. Okay, so once we fix those things, yes, we did level the occlusal plane this time, intruded a little bit more. And as you can see here, without moving the posteriors, what we got here is basically good contacts. Okay, so that is responsible. That's your force generation because in that sense, the biomechanical design is quite okay. The staging is good. Now, the activation and your plastic characteristics has to be considered as well. Okay? So, what makes a predictable treatment? And this is actually the reason, or this is actually a very nice research published just recently, just a few months ago. And what they did here is they combined or they studied thousands of patients that was performed with clear aligners. And what they found out here, the most predictable one is distalization. And as you go down here, extrusion is the least predictable movement in clear aligner movement or in clear aligner therapy. But I see this table a little bit differently. Okay? I see this table a little bit differently in such a way that I can divide this actually into. And as you can see here, this side here, your distalization, expansion, tipping, and rotation, they are actually methods of gaining space. Meaning for clear aligners, space creation is actually predictable. It's just that you just have to consider it first. That's why on the first part of your staging, it's space creation. Now, staging does make sense, right? Staging now does make sense. Now, the latter parts of the predictability threshold is actually for your manipulation. All those movements that you want to do outside space creation, that is where the manipulation comes in. And that's where you can see that predictability is a little bit lower. There's actually an explanation about it. Now, the idea here, doctors, is the further down you go, the less predictable the treatment is going to be. The further down you go, the more need for auxiliaries to be required. So what are we going to do now? Should we stop using aligners or whatsoever? Well, my answer is not. It just gives us an information that aligners alone may not be sufficient to accomplish certain movements. Okay, aligners alone may not be enough to accomplish certain movement. Now, some pure aligner practitioners would argue that pure aligners can do this. You don't need extra auxiliaries, you don't need extra help. Clear aligners can do this. Well, I would definitely agree, but of course, having low predictability threshold also tells us that we might have to increase the number of aligners. Now, for those dentists who wants to control the number of plastic that they're gonna do or they're gonna use, perhaps they're looking at other options to make the movement much more efficient. Clear aligners can be effective. but on some aspect, clear aligners may not be as efficient. Okay? So, let's talk about distalization for a bit. Now, the way I look at digital orthodontics or digital dentistry as a whole, it's still dentistry, it's still orthodontics. We just made it digital. We just made it on a simulation thing. Now, whatever you see on the simulation are just mere simulation. They're not gonna represent what's gonna happen inside the patient's mouth, but it just shows to you the objective. Okay, let's get that right. Simulations or visualizations. They are references for you to know your treatment checkpoints. The dictator or your aligners or okay, your simulation is technically rooted from your diagnosis and your treatment planning. And from the diagnosis and the treatment planning itself, it's going to give you an information how predictable your treatment is going to be. And that's usually my mission. I'm not going to flex the appliances that we do. I'm not going to boast on the solutions that we did, but rather for my audiences, for my students, for the participants that I usually get, I tend to involve them on the thought process starting from the diagnosis and treatment planning. Because at the end of the day, your aligners are just going to follow whatever you diagnosed and whatever you've set as your objective. So going into onto the distalization here, upper distalization is generally much more predictable than lower distalization, and obviously it's because the bone that is there. It's a little bit challenging to actually perform movements on the lower, not because of the size of the teeth, but also, of course, to the density of your bone. And generally, lower cortical bone or lower mandibular bones is a little bit more dense and it's a little bit more challenging to move. That's why you have to consider a few things. Now, for distalization, that's your transverse or your density objective. Another thing that might impact your predictability is actually your posterior available space. Posterior available space, doctors, is actually dictated by your the distal of your seventh to your anterior border of your ramus in the two-dimensional perspective. And the way I look at it is basically once you extract the eighths, and if you attempt to distalize, if you still have space, usually it gives you good predictability. So basically, if it is erupted upright, you can distalize around 2 to 3 millimeters safely, and that's okay. Uh, Now, if you have something like this, even on the simulation, you can distalize it. In reality, it's not going to work. Why? Because the bone will going to stop you to distalize it. Because even if you extract the eights, especially on the lower, you don't have enough posterior available space. So, starting from the diagnosis and starting from the treatment planning, deciding on the first step, which is your space creation, and right here you see that you cannot distalize, you might have to look at other options at this point. Perhaps go for extraction, perhaps go for IPR, perhaps go for expansion, perhaps go for proclination, anything that would generate your space. Now, here is another thing, and basically I have good posterior available space here. I have enough bone on the posterior, and this one. And you know the beauty of digital dentistry? We can actually dive a little bit deeper in such a way that we can actually look at your lingual cortical bones on your CBCTs, and what it does is basically it allows you to see how much you can actually distalize. Now, for this one, it's going to give me a good, even on my two-dimensional radiographs, it's going to give me a lot of distalizing space. But if I look at my CBCTs, what I'm going to look at here is, oh, I don't have a lot. I only have around 1.5 millimeters because the reference here is actually your lingual cortical bones. So if I'm going to attempt to distalize like 3 millimeters of this one, it's not going to work. It's not going to work. Why? I'm going to get low predictability on my distalization because number one, my bone actually stops me from doing 3 millimeters. At most, I can do around 1 to 1.5. This is a picture of a maxed out lingual cortical bone. And this is a study from Ridwani way back, I think, as far as I remember, 2015. And what they did here is they maxed out distalization right here. And what happens on this study is when they attempted to distalize it a little bit more, even if they have good posterior available space on the two-dimensional radiograph, lingual cortical bone technically stops it. And what happened on the second molar, instead of it moving distally, bodily, it tends to stop on the apex, and now it starts tilting distally. So now you're not getting your movement as designed. So in terms of so that's your distalization. Let's talk about a little bit on expansion and what impacts its predictability. Now, for expansion, of course, diagnosis and treatment planning is the start of everything. If your objective is to move in alveolar, perhaps clear aligners can actually work. But if it's skeletal, even if you use clear aligners, you cannot expand the bone. You really need palatal appliances. That's where your MARPE, your SARPE, sometimes surgical or rapid palatal expanders will come in for growing patients. Okay? Tooth size also is part of the consideration. If you really want to expand a lot on your posteriors, you really have to stress the importance of the expansion here. Okay? You might have to be a little bit patient, develop the expansion. And of course, considering your alveolar boundaries is actually the best way to go. If you don't have enough bone, even if you want alveolar expansion, if you don't have enough bone, it's either your teeth stops from expanding or your teeth stops from moving. So it's only something like that. Okay? Now, again, as I've said, it's all about your aligner expression, right? So your aligner expression basically considers your tooth size and the tissue reaction that is involved on your patient. Now, this is just one of the studies here. And the issue of this study is they programmed 2.5 millimeters on this side, but they generated only 1.5. The problem is that they've already reached the basal bone. Okay, they've already reached the basal bone and they cannot expand so much. So meaning, even on your simulation, it looks like it expands 2 millimeters. What happens in reality is if basically if you don't have enough bone, it stops at the point where the bone technically stops it. Now, sometimes if the bone yields, it's gonna go there, and most of the time it's gonna give you fenestration and dehiscences. Now, if upon evaluation you really wanted to do 2 millimeters, you have sufficient alveolar boundaries, and you program your aligners to move 2 millimeters here, the actual result could be around 1 millimeters. Why? Because again, plastic deformation. Plastic absorbs water, therefore, if you plan for around 2 millimeters, you're gonna get around 1 millimeters at an average. So the workaround there is perhaps expand it a bit more. Perhaps give it another 1.5 millimeter overcorrection. So instead of a 2 millimeter expansion, your technician is going to expand it by 1.5 more or 1 millimeter more so that it can go to the program 2 millimeters. So it's all about overcorrection. So sometimes doctors, you just have to be patient. All right. Now, this one usually takes around 10 to 15 aligners. Now, I am actually blessed with some patients where, yes, I can do clear aligners from the get-go. Now, just like on this patient, I can actually do clear aligners for this one. But I chose on my diagnosis and treatment planning, when I evaluated this case, I have constriction. Yes, I need space issue here. I know I have some bone remaining here. I know I can develop the arches a little bit. But my problem here is that, okay, my problem here is that the the issue or the cause why this one is constricted or why this one is like this, why my molars are torqued like this, it's not because of the teeth, it's not because of the position. In fact, it's actually because of the soft tissue presence. Now, a soft tissue problem would require a soft tissue solution, because if you try to address it with a hard tissue issue or a hard tissue thing, what happens is your muscle is still going to push it back. Therefore, your relapse rates are going to be a little bit higher. So what did I do here? I still wanted to do expansion. Yes, I can use clear aligners, but my problem is caused by my soft tissue pressure from my cheeks, lips, and my tongues. So, what did I do here? Instead of using aligners, what I did here is used an auxiliary, or not an auxiliary, but another appliance called myofunctional appliances. And what the myofunctional appliances do is they tend to train the muscles, your lips, your cheeks, and your tongue. They tend to control it. They tend to train them. Now, once those muscles are in equilibrium, where will the teeth go. So basically, your trainer, your muscle trainer allows development, allows arch development. Secondarily, tooth alignment. For all these cases that I did, especially for growing patients where I need to perform arch development, I don't usually tell my patients that it's gonna align your teeth. My primary goal here is to train your muscles, make your muscles much more cooperative, making it in an equilibrium state, and at the same time, develop the arches slightly. That's what I usually do, or that's what I usually say. Secondarily, I'm just gonna fix your alignment. We may need to use aligners or fix appliances towards the end, but if the objective is satisfactory, you might not to go to the next stage. So I tend to stage it this way. Again, staging for me, it transcends not just aligners. Staging for me is actually a whole treatment thing. Now, there, I tend to expand. I tend to develop the arches. And what happens afterwards is I did develop the arches properly. So this one. Now, if I were to do clear aligners on this, it's going to be a little bit easier. It's just a minor finishing. Just letting it flow. It's going to be a little bit minor alignment right here. I'm just going to fix a little bit of alignment. And as you can see here, much arch development without without consuming a lot of aligners, without forcing it in. Practically, what I did here is not just arch development, but we also fixed the torque of the posteriors here. Okay, so at this point, all we have to do now is just fix the occlusion a bit with clear aligners. It's going to take me around 10, 12 aligners to fix it, and I should be done. Here's what it looks like afterwards. You can see the amount of arch development that we have developed here. Profile is actually good. Facial features is actually nice. So yeah. So in terms of rotation, doctors, we have to consider the size and the shape of your tooth. Now, in terms of this predictability, basically, if your teeth is angular in nature, it's gonna be a little bit easier for you to manipulate the push. Why? Because pushing is much more reliant on flat surfaces, right? If that's the case, most of the time, rotation is gonna be generally predictable to some extent. Now, for cases that has low predictability, if you're gonna push on a curved surface, try pushing your chair, try pushing your table right now, wherever you're watching. It's easier to push because it's a flat surface. But try pushing a ball. Try pushing a ball. It's a little bit difficult. It's a little bit challenging, right? Until you get that flat surface. And that's also the challenge of your clear aligners. That's why if we're going to go back to an issue of predictability for us to actually rotate it in a much more predictable way, perhaps we should put a little bit of irregularity. And that's what we call attachments. And it's going to push right here. And it's going to rotate the whole thing. Now, of course, the size of the tooth actually matters. If you're going to rotate your molars with clear aligners, most of the time it doesn't give you that enough predictability. Not because of the motion, but of course the size of the tooth. Okay? So, in terms of this one, knowing that there are movements, or let's say even premolars can rotate to some degree. It's going to be predictable to some degree. But of course, having the size of the tooth and the shape of the tooth into consideration, sometimes if you want to increase the predictability, perhaps we can do something like this. Why not place just one single aligner right before you even start your treatment? You know that it's going to have very low predictability in rotation. It's going to consume another 20-25 aligners. And it doesn't make sense for some applications. So perhaps what you can do is do this where we cut these aligners right here. Place buttons here, and then we elicit a couple until this tooth rotates. Okay, and this tooth rotates in a much more predictable position. And then perform my clear aligners afterwards. So buttons and elastics are actually good auxiliaries. And these are combinations that I really love using in clear aligner technology. All right. So mesiodistal tipping, doctors, is generally has moderate predictability. It's a little bit challenging. Even for straight wire, it's difficult to tip a posterior teeth. You really need to perform wire bending. You really need to be a little bit more determinate on where you're gonna move your teeth. Okay, so what happens here is basically if we're gonna do mesiodistal tipping for a premolar, it's a little bit much more predictable, but of course moderately. But for your molars, having this position like this, it doesn't make sense. I mean, if you're gonna use aligners here, it's not gonna be so successful. Again, size of the tooth, properties of your plastic, and tissue reaction. Once it sets in, even if in the simulation it manages to upright, most of the time it doesn't work. Why? Because the second component, if the line of action is correct, tissue reaction will set in, and most of the time that's where you're gonna get screw ups. That's where predictability falls. That's why I would love to introduce to you another form of auxiliary. Now, this has an issue of uh, initially tipped molar. Now, the idea here is, of course, to use clear aligners to create space to stage it, a deep bite staging. So what we did here is basically place a TAD and create a wire bend, because again, we know that it has poor predictability, very low predictability, and we just placed this one. Okay, we just placed a wire bonded the bracket straight to the TAD, and aligners are continuing as usual. And as you can see here, we get significant improvements already. Now, if we were to fix this issue, perhaps we could have just added another component of a torque so that it doesn't cause any premature contacts here, giving us a better occlusion right here, even on the progress. Here's another thing that I love using. This is a model that I used for quite some time. My objective is to replace the sixes with the sevens and the eights. This is actually the mid stages of the treatment. And just to show you, we added an auxiliary called power arms and then attach it on the TAD, because this one delivers the right line of action. My aligners is basically responsible in preventing these molars to meshally tip, so that I will have room on this molar. So you can see here, I will have room to erupt or to upright this third molar here, and therefore replacing the whole thing. So this is something that we use to make the predictability a little bit much better. Now, of course, you know for a fact that visualizing your molars on with clear aligners alone is not going to be so predictable. So to increase the predictability, we might have to use auxiliaries, something like this. Okay. Another action of your auxiliaries, for example, is, for example, you're gonna do extractions, just like in this case where we have an asymmetric exo and we're looking to symmetricalize the whole thing. So what we're gonna do here is perhaps we're gonna utilize pull mechanics together with push mechanics to make sure that it actually just moves in simulation. So we've added programming. Once we program your aligners, we're gonna place the power arms. Okay. And from the power arms, basically, we're going to pull them out like this. Rotation movements are canceled out. We use the power arms to elicit the pull, and the aligners are basically assisting the whole thing. And the power arms are placed closer to your center of resistance to reduce the amount of moments that we're going to have. So the idea here is, from this aspect, now we're closing it. And as you can see, we don't have much meshal tipping going on. And towards the end, you can see that it has a nice finish, as you can see here. So that's the use of your auxiliaries. If we're gonna use clear aligners alone, yes, we're still gonna execute it, but we might need much more aligners, and predictability is a little bit lower. Now, to increase the predictability, we might have to elicit some auxiliaries that will make sure that we can deliver it much more safer and much more efficient. Now, doctors, intrusion, relative intrusion is actually okay. Okay, so they said that intrusion is previous discipline says that intrusion is actually very predictable for clear aligners, but based on the studies and based on clinical experiences, it's actually it has actually moderate to low predictability. In what way? Now, we have been led to a fact that intrusion aligners delivers absolute intrusion in studies, in retrospective studies, and even in my clinical experience, I don't see absolute intrusion on clear aligners. And that's only me, man. I mean, guys, if you have experience with absolute intrusions, I really want to know. You can, I mean, I love to do discussions with you on this one. But the concept of what we've observed so far with intrusion is that it doesn't really just, it doesn't give you that absolute thing. Relative in such a way that you can intrude on the target, but on your anchorage, it starts to extrude. So meaning it's a relative intrusion kind of thing. So the idea of this intrusion is basically, for me, is if I want to do something absolute, we would love to place TADs. TADs on the aligner so that it can elicit the intrusion that is needed for the case. And as you can see here, from this one to this one with the TADs here. No, by the way, this is not inflammation. This is just wax. We placed TAD a little bit higher. But of course, the idea here is you can see that this TAD is positioned on this area because this is where the cant is. We placed here. We pulled it up, and this is the current progress. So it's still on its way. We're still developing the whole thing, but the idea here is we're actually performing intrusion. You can see here on the change on the plane of occlusion, we're slightly being closer and closer every day. We can also get proclination. We're now getting space. Slowly, we're now getting space for this 1, 2 to actually go out. And that's actually a beautiful progress. Okay. Another thought process is with the use of your elastics. And let's say your plan is to intrude your anteriors without your posteriors actually extruding. So what happens here is that once your aligners are pushing down because of the intrusion, it has a known side effect of extruding the posterior end of your aligners, right? Now, having that said, of course, the purpose of your TAD and your buttons attached to this elastic here, to your 3 to 5 or 5 ounce, 1/4 inch, is to offer a counteracting force that whenever your aligners is engaging the attachment to push it up, your pull here pulls it down. So what happens, therefore, is it cancels out the force, and therefore you're getting this time an absolute intrusion. So meaning, we don't just use clear aligners alone. We love to use auxiliaries because auxiliaries also help in increasing the predictability. Okay? So here are some examples. This is something that we did. It's a little bit much more here. Basically, what our objective here is actually intruding the posterior segment without causing anterior extrusion. So what we did here is, instead of engaging the entire aligner system, we just engage the premolar here, and therefore, as you can see here, we develop significant intrusion right on this case, but preserving the position of our canines, our lateral and our central. So it gives us that thing. And as you can see here, from the level of this premolar to the level of this molar, now they are at the same level. So this is actually intrusion in an active sense. This is actually an active intrusion approach that we use. It's the use of your TADs and your elastics. Okay, so extrusion is one of the most challenging movement in your clear aligner treatment. Because in extrusion for fixed appliances, it's very easy. It's actually one of the default movements of your fixed appliances because it's easy for them to actually pull because of your cone theory. Now, for clear aligners, it's hard to extrude. Why? Because if you're gonna do this without attachments, you cannot. How are you gonna pull it out? Or how are you gonna extrude this central incisor? So basically, doctors, if we're gonna place it with attachments, we have your aligners to actually push to extrude. Okay? Now, here's the workaround. Sometimes performing absolute intrusion is really not that predictable. But if you're gonna combine it with another predictable movement, which is a lingual tipping, what happens is because of the motion of your moment, what happens is that when this one acts here, once the aligner acts here, it performs some extrusion and also some tipping. So if you're gonna combine a low predictable movement to a more predictable movement, you're technically getting a net result. So sometimes in terms of staging, we combine all of those things. Okay, that's principle number 2, combining movements. We can do multiple movements. Now, here's one case where we're doing like the third refinement of this patient, and the objective is just to extrude the central incisor here by pushing it this way. These are just anchorages, and as you can see, we overcorrected it by 1.5 millimeters. Sounds good. Looks good on paper, right? It should work. But here's what happened. The intention of your aligner is to actually push right here so that it can go down. So after wearing 5 sets of aligners, this is what happened on this patient. It's not yet down, right? It's not yet down because knowing that on your predictability threshold, intrusion, extrusion is one of the lowest one, and now we've intentionally performed extrusion and apparently it didn't work. So we should do something else. Should we go to fixed? No, no, no. Don't go to fixed yet. You know for a fact that predictable movements can be delivered. Predictable movements for this case can be delivered with elastics by pulling motion. So we have to do a pulling motion like so. So the pulling motion is basically adding a button on the tooth itself and adding a button on your aligner, placing an elastic here, therefore pulling it down, and eventually it's gonna look like this. So basically, we can somehow control the movements, okay? You have the power to do that, okay? You have the power to do that. Now, auxiliaries will make your predictability a little bit better, okay? It's gonna improve your predictability. In some of our cases, it improved predictability tremendously. Once we considered the 5 basic principles together with our considerations on tissue reaction, it really does make a difference. So the concept of the use of your elastics, your wire bend, your power arms, your TADs, it's not just there for show. It's actually there because we recognize that some movements are not so predictable. So that's why we added those components so that we can increase their predictability. So at the end of the day, if we're going to look at what influences your predictability, it's your biomechanical design and your force generation and body response. If you're going to use your auxiliaries, you can use a lot. Actually, you can use anything under the sun just to help your treatment. So that technically ends it, but I'm going to leave you with a bonus. Okay? Right before we go to our lucky draw, I'm going to leave you all with a bonus. Here's a bonus thing. Okay? Here's a bonus. In this case, this actually works. When we feel like we are doing nothing, we are actually doing something. Doctor, what do you mean? How is it going to happen? Or how does it come to be? Let me show you something. This is one case. When I first saw this case, I mean, yeah, it's a functional thing. But when I submitted it when I asked someone to get another second opinion, they just wanted to move the central incisors here on this side. And obviously, it is a functional shift. You can see it on the face of the patient. So what did I do here? I just asked them to manufacture, give me a passive aligner on the upper and on the lower. And what it does is it deprograms the mandible. It deprograms your pterygoid muscles so that it also allows a little bit of remodeling on your joint. So that from a deflected position like this, in month 4 with the same aligner, we have improved this thing. There's no staging, no sequencing. It's just 0 passive aligners. And here's the case of the patient on the 4th month. And here's our case now, right before we even start. And you can see now that the intra-arch is now coinciding. The reason why I placed attachments here is because I've recognized the interferences are coming here. Now I'm okay to expand. So at this point, I just waited 6 months, only one aligner. And then on the month 6, that's where I actually bonded my first aligner. So in terms of diagnosis now, in terms of predictability, I'm just going to expand this one. On the lower, perhaps extract one premolar and then pull it back because it's going to end up in class 3 anyway. So it's going to make my life a whole lot easier, right? So diagnosis and treatment planning is still the key for everything. And we invest so much on diagnosis and treatment planning. SEBARIS is like that. We just happen to make aligners. Okay?